Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
All right, I think we will go ahead and get started. Again, thank you everyone for joining us today for this presentation on bone health with Dr. Dawn Beringer. I'm Emily Brown. I'm the Program Director at Cancer Support Community Atlanta. I have been inviting people to put in the chat where they are joining us from, whether the city and state, just so we get an idea of how far our reach is with this program today. But just so you know, you are going to be muted throughout the program. We invite you to ask any questions you have for Dr. Beringer in the chat at the bottom of the screen. And also Dr. Beringer is going to be asking you all some questions. So if you want to give an answer to one of Dr. Beringer's questions, you can also submit that in the chat. And we will be fielding questions as they come and also leave time at the end for Q&A. So I think we'll go ahead and get started. Dr. Dawn Beringer is a board-certified orthopedic surgeon who specializes in the diagnosis and treatment of arthritis and chronic pain, joint pain of the hips, knees, shoulders, and while offering the latest therapies and surgical procedures to reduce joint pain, optimize function, and restore patients' quality of life. Dr. Beringer takes pride in helping patients become active participants and experts in their own care. Specializing in outpatient and total joint replacement, Dr. Beringer uses the latest in minimally invasive surgery, allowing patients to go home within hours of their surgery with less pain. Additionally, Dr. Beringer is dedicated to advancing the understanding of complex surgical techniques and has published his research extensively. He serves as an associate editor for the Clinical Orthopedics and Related Research, a leading international orthopedic publication, and has served as an assistant professor at the Department of Surgery at Mercer University School of Medicine. So without further ado, I will hand it off to you, Dr. Beringer. Thank you.
Emily, thanks so much for the introduction. I'm very happy to be here to speak with all of you. Thank you so much for taking the effort and time to log in and be a part of this discussion. One of the questions that I do have for you as you listen to the talk and you have the time to do it, tell us what your particular interest is, because toward the end, I'll look at the chat and Emily and I will be looking at that and get a better feel for where people are coming from and maybe what some of the questions that you have around bone health. We're going to discuss today the broader area of bone health, but also focus some of the talk in on, hang on one second, sorry, please, yeah, we'll just, thanks a lot. Okay, so we're gonna focus some of the talk in for kind of more specific for cancer survivors. And a lot of this applies to all of us, whether we're cancer survivors or not, especially as we get on in years and need to be more competent in understanding, what we need to do to maintain our bone health and thereby maintain our mobility. So there's 15 million cancer survivors in the United States, and that number is growing. This is 4.5% of the U.S. population has had an experience with cancer. That's an incredible number. The incidence of cancer is greatest in lung, followed by breast, prostate, and colorectal cancer. But the prevalence, due to the varying survivorship of each of these types of cancers, is that breast cancer survivors are the most prevalent in our community, followed by prostate, colon, and lung. There's a large proportion of all survivors that have disease-related bone and musculoskeletal health issues. It is estimated that between 15 and 20% of all patients with cancer do have some significant osteoporosis, either due to the direct or indirect effects of the cancer or its treatment. Bone mets occur in over 70% of patients with breast and prostate cancer. And so that's another significant factor in terms of the propensity to develop low bone mass. Other musculoskeletal events that occur in cancer survivors during or following treatment, even in periods of time when they're disease-free, are fractures fragility fractures, falls, deconditioning, postural changes, bone and joints symptoms, and then musculoskeletal problems that relate to vitamin D and calcium deficiency. There's a little bit of background noise. I'm wondering if is there some way we can mute that? I'm not sure. Okay, so 10 million patients in the United States have actual osteoporosis, and that's only a proportion of the total that have some pathology of bone health. There's another several million that have low bone mass. We doing the research, there is approximately 9 million patients that have fragility fractures. This does not include people that fall from a ladder or from heights or car accidents or other traumas. These are people that have ground level falls or other innocuous trauma that results in a fracture due to low bone mass. So a total of 54 million have either osteoporosis or low bone mass. 1 out of 3 women and 1 out of 5 men will have an osteoporotic fracture. So osteoporosis and low bone mass is certainly a major health problem that we can discuss throughout this talk. There's an intersection between cancer patients and osteoporosis. As we mentioned earlier, 15 to 20% of cancer survivors have osteoporosis. So it's a major problem, and it's becoming a greater problem because of the prolonged survival. The great news is that many of the treatments that have been coming down the pipeline for management of cancer are also resulting in a much longer lifespan, but the long-term effects of the cancer treatments and the original cancer itself have raised a number of problems. One of them is this issue of bone health. So obviously metastatic disease, metastatic bone disease is a direct effect on the health of the bone, certainly causing a focal osteoporosis, if not a generalized osteoporosis. And the indirect side effects are due to cancer-specific therapies or the inactivity associated with recovery from treatments for cancer. These can be early or late onset. There is a dramatic loss in bone for some of the interventions associated with cancer, and we'll get into that a little bit later. So what does normal bone look like, and how does it form, and what's the physiology of normal bone? As you can see, bone has a outer compact, dense cortex, and then it has an inner spongy area that has a lot of different functions. The medullary cavity is the center of the bone, and the cortex is on the outside. Bone is 35% of our body weight. It's made of 20% of water. It's made of collagen, which is kind of a protein rope that's interweaved with a matrix of calcium and phosphate crystals. So it has a real crystalline, hard aspect to it, and then more of a protein aspect to it that's the collagen. Within the medullary cavity, in that spongy area, is the marrow where blood cell production and fat storage occurs. On a very microscopic level, there's units of kind of a physiologic unit of bone that's called the osteon that has all of the structure necessary for normal bone turnover. It's a living tissue. It's very active and must be so throughout life in order to be supporting our body appropriately. Of course, it supports our organs. We couldn't function without a supportive skeleton. It protects our vital structures, our breathing, all of our vital organs. It allows mobility, and it maintains our body's calcium homeostasis and our mineral balance, which is critical for life. As we mentioned a moment ago, it stores our blood cell precursors, fat for energy, and minerals in the medullary cavity of the bone. It produces blood cells for carrying oxygen and fighting infection as well. So healthy bone is continuously regenerating it's a balance of formation and resorption. This goes on throughout life. In our early years, up until we reach peak bone mass, our balance is in favor of formation. And then as we get on toward the age of 50 and beyond, the balance falls in favor of resorption. And that happens in everybody. It's a matter of degree in terms of whether we get into a pathologic state. There's specialized cells that signal proteins to balance this remodeling process. As you can see in this diagram, in the center is what's called the osteoblast. That's a precursor of a bone cell, and that osteoblast is under the appropriate environment and with the appropriate signals going to lay down immature bone. An immature bone is called osteoid. That immature bone then is remodeled and is interweaved with calcium and phosphorus in a crystalline matrix to form what's called that calcified bone matrix. Meanwhile, as that's occurring, there's a feedback loop going on with the activation of osteoclasts due to signaling proteins that are coming in right behind the osteoblast to resorb bone, and this goes on and on throughout life. Our entire skeleton turns over and regenerates several times in our life. So what is the problem when bone resorption exceeds bone formation? Well, we call that osteoporosis at some point. We call it low bone mass early on and osteoporosis as it reaches beyond a certain threshold where the risk of fracture, bone pain, and mobility problems becomes significant. So this imbalance of bone remodeling results in a net resorption over formation. It's a decreased amount and quality of both the outer cortical bone that we just talked about and the inner spongy bone. So we really lose bone both in the center and out toward the outer parts of our bones. You can see this on X-rays, and you can see it with bone density tests that we'll mention later. So this is a real risk for fracture and a major health problem. It's a $20 billion problem annually as well. So as we mentioned, you get pain, you get fractures, but you also get postural abnormalities associated with the reduced activity and pain of osteoporosis, so that you can see on the right where this schematic of a erect skeleton eventually evolves into this more contracted state where the head is forward on the rest of the spine, which raises the effective weight of the skull. It further increases the risk of compression fractures in the spine, and it just makes life, our quality of life reduced. So what are those risk factors for osteoporosis? Well, underlying all of the risk factors is the simple fact that some of us have a genetic predisposition to low bone mass. And that really, we will see, it plays out in terms of what happens in our early years with a reduced peak bone mass. And it plays out in terms of what happens in our later years in terms of the rapidity of resorption of bone in our 50s and 60s and beyond. So low peak bone mass is possibly the most important factor that plays into the development of osteoporosis. It's just that it's a factor that occurs so far in advance of when we actually have the problem in most cases. We develop an accelerated accumulation of bone in our teens and early 20s, so that by the age of 30, we've hit our full genetic potential in terms of our peak bone mass. And you can see the implications of this in the lower right, where if we have a peak bone mass in the first curve where it says full genetic potential, then we have a lot more bone to work with as we get into later years, when for females menopause, or for males when their testosterone levels are dropping off rapidly, you have at around the age of 50, you start to drop significantly, where you're losing, 1 or 2% of your bone mass per year. If you start with a low peak bone mass, then you're going to get into that fracture risk at an earlier age. And so many of us on the phone, we can't do anything about that now. We certainly can pass that information on to our children. We can educate others in our community, but that is that's come and gone for us. And we just have to address what we can wherever we are between these two lines or even below it. But what are those things that lead to low peak bone mass? Well, very athletic adolescent young girls sometimes can experience amenorrhea, or for other reasons, eating disorders or just hormonal imbalances. We can get significant changes in our hormonal environment as a result of either amenorrhea or other problems in childhood and adolescence that can lead to a period of time of bone resorption exceeding bone formation. And so that's a factor. Any kind of prolonged childhood illness, whether that's an inflammatory disorder or, in the case where childhood cancers occur, this is going to be a real risk factor for low peak bone mass. And then all of the treatments that go along with cancer in childhood apply as much as they do in adulthood. Chemotherapy, bone marrow transplants, and the extended inactivity that occurs in association with cancer treatment certainly results in lower peak bone mass. Dietary deficiencies used to be common, with rickets occurring on a much more common basis in our society, but with the fortification of food, especially milk, with vitamin D, we have not seen that. But there are other dietary deficiencies and malabsorption syndromes that manifest in childhood that lead to a low peak bone mass. And finally, low physical activity or limited sun exposure can certainly lead to lower peak bone mass than otherwise. So what lifestyle factors play into the occurrence of osteoporosis? Well, lack of weight-bearing activity is a very significant factor. There's been many, many studies showing that weight-bearing activity in adult life over a prolonged period of time has bone-preserving effects. And they've worked this out in terms of the physiology of why that occurs. There's really no mystery to that anymore. It's just a matter of how much it can turn things around for us later in life. Excessive alcohol intake influences bone density, and the quantity or the frequency of alcohol intake can have an influence. Smoking is a really bad actor in terms of bone density. And then inadequate dietary intake of protein, calcium, vitamin D, and other vitamins, as well as the intake of carbonated beverages that seem to have a deleterious effect on bone. Again, minimal outdoor activity. We want to be mindful of the adverse health effects of the sun and use of sunscreen, but we also have to have a balance because of the vitamin D activating effect of the sun that occurs and allows us to have a much more powerful form of vitamin D in our body. Hormonal influences certainly play a major role. We've been aware of that for many, many years. And there are age-related hormone changes for both sexes, not just for women, but the fall off of estrogen and menopause, and then the drop in testosterone is rather dramatic for men in the 50 to 60-year-old age group. Estrogen deficiency in women at an early age or later on is a factor, and total hysterectomies in premenopausal women is a factor that has a dramatic influence on the occurrence of osteoporosis. There are endocrine disorders earlier or later in life can have a devastating effect on our skeleton, particularly hyperparathyroidism or hyperthyroidism, as well as Cushing's disease, which is a disorder of corticosteroid metabolism. So you can see that sex hormone production, it hits 100% for males in their early 20s and for females in their late 30s, but there's a dramatic fall off of estrogen at menopause, and there's a more gradual fall for for males over a period of 20 to 30 years. Calcium and vitamin D deficiency are particularly strong influencers of osteoporosis, or the occurrence of it. Inadequate intake of vitamin D or malabsorption can lead to vitamin D deficiency, and again, limited sun exposure, and then liver or kidney failure can influence our active vitamin D levels. Again, inadequate intake or malabsorption influences calcium uptake. Medications can do that, alcohol can do it, and so can the ingestion of coffee or tea. That was a full feedback. Vitamin D deficiency influences our calcium absorption. So these are all very interrelated factors. A drop in calcium, if we have decreased calcium intake, then we have less absorption, and then we have less circulating calcium, which triggers our parathyroid hormone to increase, and that leads to increased bone remodeling and bone loss. So we want to keep our calcium levels satisfactory. So many medications induce low bone mass or even osteoporosis. The worst actor, at least in terms of the most people that are adversely affected, is corticosteroids, whether it's being taken for immune disorders, for asthma, or for musculoskeletal complaints, or whatever the reason. Corticosteroids have a profound adverse effect on our bone health. And so we should limit the use of corticosteroids when we can. We can't always, but when we can, we should limit the dose or the frequency. Methotrexate, diuretics, of course, as we've mentioned, estrogen, androgen blockers, some antidepressants, specifically SSRIs, those are serotonin reuptake inhibitors, have an effect on our bone health. Traditional chemotherapies, we'll mention later, do some affect bone health and some don't, but there's a growing number on that list. And there's even some targeted cancer therapies that have been released in the last 10 years that are now showing some signs of affecting or influencing the occurrence of osteoporosis. Not all anticoagulation medicines will cause low bone mass or osteoporosis, but Coumadin and heparin particularly do. Reflux medicines, those proton pump inhibitors, protonics, and drugs like that do cause some decrease in our bone density. And then finally, anticonvulsants have been long known to influence our bone health. So what's my risk for a fragility fracture? How do we know that? There's been a risk assessment tool that's been developed, and I just wanted to mention that there is actually a way to quantify your risk of a fracture on an annual basis, and it takes into account a history of fragility fractures, whether one of your parents has had a hip fracture, the occurrence of smoking or not, cortisone administration, rheumatoid arthritis, and whether you've had other causes of osteoporosis that are identified, such as cancer, and then whether you drink 3 drinks per day or more. That, together with your age, your weight, your gender, and height, can be used in a tool that can give us a risk of a percentage risk of fracture. So osteoporosis, we've mentioned already, it causes pain and postural difficulties, fracture, and it really causes a lot of apprehension in life because, similar to balance disorders, there's just a fear that that a physical activity can cause a fracture or some pain that otherwise wouldn't be there. Similarly, patients with cancer that have metastatic disease to the bone likewise have pain and fracture, but they also have metabolic disturbances and they can have complicated management issues because of their bone mets. But at the end of the day, there's musculoskeletal breakdown, which causes pain, stiffness, falls, and loss of mobility. So prevention and effective management definitely results in improved quality of life with or without cancer. So why is there a prevalence of osteoporosis in cancer survivors? Well, there's direct and there's indirect effects. 50% of cancers develop some form of metastatic bone disease, so this is very prevalent. The direct effect of a metastatic deposit of tumor in the bone is not just due to the space-occupying effect of a cancer in the bone, but it influences the physiology of the entire regional area of the bone through signaling proteins that induce resorption of bone just by virtue of the proximity to metastatic tumor. Cancer therapies profoundly can affect bone health and bone density, inactivity associated with recovery periods, surgeries for cancer, such as GI surgery, colon resections, thyroid removals. Other surgeries can have a profound effect on our bone metabolism. Radiation focally can cause severe osteoporosis or just reduced density of bone. Finally, bone marrow transplant can profoundly affect our bone health to the extent that we should be evaluating baseline bone density in patients that go for bone marrow transplant. Increasingly, that's being done. And then nutritional deficiencies that might be associated with the side effects of cancer treatment, chemotherapy, and the like. So which cancer therapies are we talking about that can influence osteoporosis? Well, hormonal modulators, particularly in breast and prostate cancer, we do see that there are endocrine modulators in thyroid cancer, but we're really talking about these estrogen blockers, aromatase inhibitors, and androgen deprivation, such as Lupron, that affect our bone health profoundly. Chemotherapies, methotrexate, ifosfamide, cyclophosphamide, fluorouracil, imatinib, and cisplatin are the main categories of chemotherapies that can profoundly decrease our bone density, but there's others as well. Glucocorticoids are used in nausea management as well as part of chemotherapy protocols. And so those added together with other therapies can have a profound effect on our bone density. Even the anti-nausea meds that are used in chemotherapy are now shown to cause osteoporosis. When we diagnose osteoporosis, we, like most things, we'll start with a history of fragility fractures or a family history of fragility fractures, certain medications we're looking for to indicate that we may be dealing with the problem of osteoporosis or at least low bone density. On exam or together with history and exam, a significant loss in height, postural changes that are just telltale, which are like kyphosis of the upper thoracic spine, or where the head is much farther forward than it's been in previous years, together with decreased strength and muscle girth, indicate that we might have a patient that's at risk for low bone mass or osteoporosis. The DEXA scan is the kind of the centerpiece imaging study that has been proven to correlate with the risk of fracture. We use a T-score, which is a bone density that's normalized for your age group. If you have a bone density that's one standard deviation less or one standard deviation more, within that range, we call that normal. But if you drop to less than one standard deviation below normal, we call that low bone mass until you get to 2.5 below normal, at which point we call it osteoporosis. And that's not just an artificial difference. Those numbers have been established because they are cutoffs that correlate with a much higher risk of fracture. Blood tests traditionally have not been done for osteoporosis, but increasingly they are. Vitamin D levels, the hydroxy vitamin D is a blood test that you can get. It's readily available, and we shoot for a level that's above 40. If we can show that you have normal vitamin D levels and you have a T-score that indicates a risk for fracture, then you'll be given vitamin D and calcium supplementation, but maybe not to the same extent that somebody that has a low vitamin D and a low calcium. So that baseline calcium and vitamin D level and a periodic retesting of those levels does inform the dosing and the frequency of replenishment of oral replenishment of vitamin D, or even sometimes IV replenishment, depending on the situation. There are hormonal tests, such as parathyroid hormone tests, and then markers for bone turnover that become important in less usual circumstances. So this is kind of the money slide. It's busy. There's a lot of bullet points here, but I think it's important that, we're all kind of here because we want to know how to stay in the game and keep our bone health from keeping us out of normal daily activities. I think it starts with determining our risk. Taking a good inventory of our own family history and getting a baseline of our bone health. And with some of the information that we provided, you can start to kind of formulate your own thoughts about whether you have risk of fracture from osteoporosis. But basically, that DEXA scan becomes a major baselining imaging test. And I think that that test just can't be overutilized. I really, I think the insurance companies will support once every 2 years, but there's some indications for using it more often. But really, it's an underutilized test if you look at across the board for different risk groups. So basically, let's baseline our bone health, and to the extent that we get a DEXA scan, I think that would help. Blood tests sometimes are helpful, sometimes they're not, but they're out there and they're useful in some circumstances. We need to have a commitment to daily weight bearing and resistance exercises. We need to have proper levels of vitamin D and calcium replenishment. These supplements can be overused as well. So we have to get smart on where we are and what we need to everybody isn't the same. There are some standard dosing and frequencies, but not everyone is the same. And we need to address nutritional deficiencies. Of course, avoid smoking and limit our alcohol intake. We should be getting daily outdoor activity. We need some sun exposure. I work closely with some surgical oncologists that work in the area of melanoma, and so their push is to try to protect people from sun exposure because they see the health effects of overexposure to the sun. But we do need some for adequate bone health. We need to address hormonal problems early and aggressively. And as we've already seen, the earlier in life that we do all this, the more effective it will be for us in the long run. And then at the end of the day, we need to consider bone stabilizing agents as well. We'll talk about that in a moment. In terms of nutrition, think of foods that have calcium and vitamin D in them. Milk, yogurt, cheese, green vegetables, and selected nuts have high levels of calcium in them. Fortified milk, fortified yogurt, cereal, or orange juice, as well as salmon, canned tuna, carrots, greens, and cod liver oil have high levels of vitamin D. So what is the dose and frequency that we should depend on to maintain our vitamin D and calcium levels? Again, depends on our baseline, but between 800 and 1,000 international units a day is not excessive, and most would recommend that you have at least that much. Now you can overdo it, but with normal vitamin D levels as a baseline, this would be a good standard. Taking this in divided doses makes more sense because we lose a significant amount of our vitamin D that's ingested orally, and that also goes for our calcium requirements of 1,200 to 1,500 units a day. We need to take that in divided doses. And that's one of the reasons that it's recommended that you get most of your calcium from food sources rather than from a oral supplement. So sun exposure activates our vitamin D to a much more powerful form of vitamin D, vitamin D3, and 20 minutes of sun exposure 3 times a week is actually enough. Maybe maybe a little more than that, but basically you don't have to have a lot of sun exposure. And sunscreen really is not, for the most part, is not going to block out enough sun for you not to get any vitamin D effect if you're out in the sun for a significant portion of the day. Weight-bearing exercises, I can't emphasize enough the importance, because this has not only, it has an effect on our mind and our body as well. It affects our posture as well as our bone density. So I think this is something that we are, as a society, we're understanding this more, but I think that we still need to continue to educate people and to provide the training so that people can get into a routine and feel confident with a program that stresses their bones and builds muscle, okay? Resistance training, walking, isometrics. As you can see, this girl on the right is doing a wall sit, and some people don't have the strength or maybe knee arthritis that would prevent them from doing a full 90-degree wall sit, but that kind of activation of the quadriceps muscle and co-contraction around the hips and knees will help to build bone and strength and balance, as well as posture. See how her back is all the way up against the wall, and she's practicing this avoidance of that curved posture that is so telltale of the patient with low bone mass. And you can see over here on the left this example of an extension exercise. I mean, you have to have the right technique here and build up slowly, but that's a very good exercise for stressing the vertebra to build bone mass and to improve the posture and maintain it. Bisphosphonates are one of the classes of bone stabilizing agents that reduce bone turnover. These are what we call analogs of pyrophosphate. So the crystalline structure of bone, they insert themselves into the bone and they actually kill the osteoclast, the cell responsible for resorbing bone. Zometa is the most common of the bisphosphonates. It's an IV infusion, typically every 6 months or every year, but there are differences depending on the severity of osteoporosis. Common side effects include occasional flu-like symptoms and hypocalcemia. Fosamax, we've heard about that over the years, and it's an oral, daily, or weekly. More typically, I see it given weekly. It's supposed to be taken on an empty stomach. It can cause some GI upset and esophagitis. And then Boniva is another that is an injection every 3 months. Long-term complications of these bisphosphonates include kidney disease, osteonecrosis of the jaw. That's one of the most feared complications at about 3% for those who have been taking it for more than a year. Also, hypocalcemia and atypical femur fractures can occur over the long run. It's ironic, but that if you're on this for closer to 3 to 5 years, you can sustain these fractures that are a result of lack of bone turnover. Denosumab is another anti-resorptive bone stabilizing agent. It's an inhibitor of the osteoclast, which is the cell that resorbs bone. It's a monoclonal antibody. It's injected usually every 6 months for this indication, but that can change depending on the circumstances. It's more convenient than having an IV infusion, but it's certainly more expensive as well. The long-term side effects are similar, but not the same, not exactly the same as the biphosphonates, including atypical femur fracture, osteonecrosis of the jaw, and hypocalcemia. So you need to be monitored if you're going to get on one of these drugs, and your primary care physicians, oncologists, rheumatologists often take the helm on this. Finally, estrogen receptor analogs. There is controversy regarding estrogen receptor analogs because the estrogen receptor is is at play in so many of breast cancers. And so there's a potential risk of inducing breast cancer or reactivating breast cancer. And there's also a risk of venous thromboembolism with some of these medications. Tamoxifen has been used because it tends to build bone for postmenopausal. It doesn't work the same way in premenopausal women, but in the postmenopausal state, it tends to have a bone stabilizing effect. And then raloxifene is the more common Evista estrogen receptor modulator for this problem. It's a daily medication. It's the first line for patients who've had a history of invasive breast cancer and severe osteoporosis. Again, my experience is that the oncologists are not likely to want to see this on board if there's been a history of breast cancer. But there are circumstances when people have so severe osteoporosis that all options have to be considered. Side effects include VTE, venous thromboembolism, hot flashes, and then there is a rare circumstance of stroke with this as well. So parathyroid hormone analogs are considered bone builders. They don't stop bone resorption, but they actually stimulate bone accretion and increase bone density through a daily subcutaneous injection. They're generally avoided in patients with cancer because there is some, at least theoretical, risk of osteosarcoma, more found in animal models, but certainly not something that anybody wants to mess with. The maximum treatment is 2 years because the effect is just not sustained over a greater period of time than that. Just a couple more comments on bone mets before we wrap up. But bone mets are clearly cancer that spreads to the bone, most commonly, as we said before, lung, breast, and prostate. Cancer cells have an inherent attraction to bone due to the growth factors that exist in bone, the chemoattractants in bone. It's not just that they're randomly floating around in the blood and they find their way to the bone. There is some element of that, but it is also that there's kind of a homing process that people have identified in terms of the attraction of cancer cells to bone. There are osteolytic or, like holes in the bone as a result, osteolytic lesions that are holes in the bone as a result of bone mets. And then there's osteoblastic, which is more where it lays down extra bone, it's space occupying, and it's a kind of a whiteout in the bone, and it occurs more common with prostate than other cancers. Obviously, the danger of bone mets is fracture, severe pain. With bone mets, you interfere with the bone mineral metabolism, which can cause electrolyte imbalances. With the space occupation of deposits of metastatic disease and the influence on bone, you can get nerve compression or weakness. Imaging for patients with bone mets is not a routine screening process for bone mets if patients don't have bone pain or some suspicion. And the type of study certainly depends on whether you're looking for widespread or one particular area. But we almost always get plain X-rays. Other studies include bone scans or PET scans. PET scans are common in many of the different cancers these days. They're more expensive, and the insurance companies fight with us, but a PET scan is very common in terms of following patients for bone mets. But we get MRIs and CT scans as well. In multiple myeloma, it's worthy of mention that whole body MRI or low dose whole body CT scan is a surveillance method that's been used recently, and it continues to be developed and popularized. So the treatments of bone mets include, of course, chemotherapy is effective in controlling bone mets. It has a lot of downstream effects that we've talked about in terms of osteoporosis. Hormonal therapy, immunotherapy, or targeted therapies are now much more common than they were even 5 years ago. Radiation is giving way to some of the other targeted therapies in some of the diseases such as myeloma, but it's still a cornerstone for managing patients with bone mets. And then finally, surgery is very uncommon, but is extremely helpful for patients that have impending fractures or completed fractures, or just have severe pain that can be stabilized. But again, not real common. So that wraps up the formal part of this talk. But I did want to turn it back over to Emily for just a moment to kind of just reintroduce you to the platform that we're on right now, which is the Cancer Support Community. It's an unbelievable organization, has been such a support for so many patients in different stages of their treatment. And I'll just let Emily speak to that a little bit more.
Thank you, Dr. Beringer. And we did have quite a few questions come in the chat, so I didn't want to interrupt you while you were on a roll, but we will get to those.
Okay.
Yes, thank you so much. The Cancer Support Community, of course, is the local network partner of a larger national organization. We provide free support services to people affected by cancer. That's cancer survivors and their caregivers. And we've had a wonderful affiliation with Northside Hospital Cancer Institute for over 20 years here in Atlanta. So we're very proud of that. And we offer a wide variety of programs and classes to support survivors and their loved ones during treatment. And of course, all of our programs are free and led by licensed professionals. So if you'll go to the next slide, we have information on our next presentation, which is with Dr. Nicole Kounalakis on an update on management of melanoma. So that will be July 6th at noon, and you can register on our website, cscatlanta.org. We'd love to see you there. All right, are you ready to get into some questions?
I sure am, if,
All right.
if the group is.
So we've got a few early on in the presentation about osteoporosis. Someone said that they're interested, they have metastatic prostate cancer and want to know more about androgen deprivation therapy related to osteoporosis.
Okay, so I'll tell you that it's not only real, it's something that I think has been recognized more just in the last few years than previously. And part of the reason is that we don't think of men as having osteoporosis as commonly, for one thing. But the other is that prostate cancer metastatic to bone has the appearance, as we said a moment ago, it's called blastic. It's kind of got more a whiteout to it. And because of that, we tend to think of it as less likely to fracture and more dense. While the lesion itself is a little bit more dense than normal bone, it's weaker than normal bone. And the area around these lesions is osteoporotic because of the androgen deprivation. We don't think of lack of testosterone as a factor in osteoporosis, but it is a very real factor. And in fact, testosterone gets converted to a cousin of estrogen in our bodies in order to maintain our bone health, even in guys. So if we don't have the testosterone to convert because it's been blocked by the androgen deprivation, then we've got all the setup for osteoporosis. In fact, I saw a patient today who was referred for me to evaluate whether they have a new bone met from prostate cancer or whether it's a stress fracture due to osteoporosis. And I mean, you can't tell by looking at the x-ray that this person has osteoporosis, but he has had androgen deprivation for many years, and I know he has a stress fracture. We're going to go ahead and get some other imaging studies to nail the diagnosis. But the bottom line is that it's very much connected, and you have to. My recommendation is get a baseline bone density test called a DEXA scan, and discuss it with your doc as to okay, where do we go from here? Does it look good? Am I in good shape as far as my bone density or not? And if not, then you can really start working on some supplements and several of these different levers that you push to improve your bone density.
Thank you. Another question. I am post-breast cancer and have been on Arimidex for several years, recently discontinuing it. My bone density is starting to be affected. I have osteopenia now, and I'm hoping for suggestions to prevent further progression.
Okay, so then the question is, are you also on a a bone stabilizing agent, and that may be something that you have to consider for a year or so. But that's a tough call because without the right information, and certainly is in the realm of your medical oncologist. But so now that you're getting off Arimidex, are you getting back on another drug that has some estrogen blockade, but is not as severely affecting affecting the osteoporosis as Arimidex is? There are some options. And then the other thing is, have you looked at your baseline vitamin D and calcium levels, and then come up with a supplement plan that makes sense for where you are with that? And then finally, I do sound like a broken record, but aside from the supplements, you need to have appropriate protein intake too, because all of this bone density talk goes nowhere if you don't have the building blocks of bone metabolism, which starts not only with vitamin D and calcium, but with protein. So you've got to have adequate protein. You've got to have your nutritional house in order. And then you've got to be doing weight-bearing exercise. Now, there's problems with people who have arthritis in the hip or knee or back, but there's always something that can be done. I even showed a picture of somebody laying on their stomach and doing some Supermans, where they're raising their arms and extending their back. That is in effect a weight-bearing exercise. So the long story short is, get going on an aggressive plan for supplements and for weight-bearing exercise and proper nutrition.
They did say that
the final thing on that. One second. The final thing on that is definitely have a serious conversation about either Xgeva or there's Prolia or Xgeva, which are in one category. That's a Denosumab or a bisphosphonate. So that should be part of the conversation. When to pull the trigger on those is art as well as science.
They did say that their doctor suggested taking calcium supplement, but their supplements they've tried bother their stomach and they have significant constipation.
Okay.
Recommendations.
Okay. Well, you got to keep fighting this. You got to keep, there's different options. There's gummy bears that are lower dose, and you can take a much smaller dose a couple times a day, or you can take a much smaller dose with your food, or you can really dive in. This takes time, but you can dive into which foods, but you do need to know what you're taking, because natural foods are always going to be better sources of calcium. And if you can start to adjust your diet with food, then you're going to get it that way. You don't need more than 1,500. Maybe for you with osteopenia, you might need 1,700 of calcium, but you'd be surprised how much of that you can get with natural foods. And don't forget about vitamin D too, okay? Because you need adequate vitamin D to absorb the calcium.
Thank you. All right. I think you might have gone over this, but does long-term use of letrozole enhance osteoporosis, hearing knee popping and hip soreness? This individual.
Well, okay. So there's a lot of overlap there. Long-term use of letrozole, yes, to the question of osteoporosis, but osteoporosis absolutely is not associated with knee popping, and some musculoskeletal pain is a separate side effect of letrozole. So, you might be having a side effect that's more musculoskeletal pain oriented, joint pain, and not osteoporosis. So make sure you get clear on, what's happening with data. Meaning, I want to know what my DEXA scan says. I want to know what my vitamin D and calcium levels are in my body. Calcium is probably okay, but your vitamin D level. And then, attack what needs to be attacked. But yeah, the long answer short is it certainly does affect your bone density.
All right. What about taking Tums for additional calcium?
It's reasonable. I don't know the exact amount, off the top of my head, but back to the other individual who was asking about. Yeah, I think that might be calcium carbonate, and I don't know the biological effectiveness of calcium carbonate versus calcium tartrate or these other, different formulations of calcium. So I do know though that there is you're gonna get some calcium from Tums. I would look on the bottle to see, what you get, or look it up online to see what your what your dose of, how much calcium you get with Tums. But again, for everybody on the call, I just want to remind you that calcium and vitamin D, but now that we're talking about calcium is not going to be absorbed efficiently by the body. And any kind of like even mild malabsorption is going to make it worse, so that you need to take it in divided doses. So I go back to natural foods, and taking, if you're, don't just dump a lot of Tums. Take them, if you want to take 2 or 3 Tums a day, or let's say 2 Tums a day, take one at one time, one at another. That's the way you really get your calcium levels up.
Right. We've got a question from one of our nurse navigators. Do all barbiturate drugs cause bone loss, or just phenobarbital? Also, have you had any patients who take butylabital, an ingredient in fiorinol used for migraines, that have developed bone loss?
Yeah, both of those drugs have, they cause what's called osteomalacia, which is a little different than osteoporosis. It's more a direct effect on vitamin D metabolism. And I can't really walk through all the detail of the mechanism, but yeah, you have to be monitored. And certainly with bone density tests, because ultimately that can affect your bone density. And there are, times when, you have to find alternative drugs based on, what's going on with your bone. So, I'm not an expert on phenobarbital or phenytoin drugs, but, anticonvulsants and phenobarbitals are bad actors over a long haul. So you just have to, monitor what it's doing to your bone density, what's doing to your vitamin D. And there's even times when you have to get a bone biopsy to see what's happening with your bone if you have a real problem. But that's very unusual to have a bone biopsy. A lot of times you'll be looking at alternative medications.
All right. We just have one more minute. I want to be mindful of your time, Dr. Beringer. I know you had a hard stop at 1, but I'll just try another question. Does Synthroid reduce bone mass? My thyroid was removed 20 years ago, and I've been on Synthroid since. I'm now 55. I was on tamoxifen for 5 years, and I was premenopausal. Am I at higher risk for osteoporosis?
Well, Synthroid, the goal of Synthroid is to make you what we call euthyroid, meaning make you function as though you have normal baseline thyroid function, but it can kick you into hyperthyroid, or you can still be hypothyroid with Synthroid. And so it might be worthwhile to look at what your thyroid hormones are doing to see if you're running, low-level hyperthyroid. Because if you're low-level hyperthyroid, that can lead to low bone density. So you can get some resorption with hyperthyroidism, but I don't think the drug itself is a cause of osteoporosis. And now I'm going to write that down and check on it, but I don't think that is a cause by taking the drug itself. It's a matter of whether or not, there's a balance that you reach when you take that drug. And so if it's kicking you into mild hyperthyroidism, then that would be a concern.
All right. We are at 1:00 now. So we still had a few more questions. I'm sorry that we weren't.
We got a little bit of time if people want to stay on for a minute or two longer. Okay.
Any suggestions where to find weight-bearing exercises to do? I need help finding a trainer.
Gosh. There is somebody there's a place called SFX up on 92. That's in Roswell. I can't remember the guy's name, but my gosh, there are people that specialize in osteoporosis. I'll tell you what, Emily, why don't you take that person's name and let me dig around a little bit and see if I can find the trainer that I have heard, works with people with osteoporosis. And I'll tell you what, it is so important. I don't understand why there aren't more people. There should be one on every street corner, because the exercises that you do for this are so important, and they pay off like within a week, and people feel better, very quickly. And they get more mobile, balance improves, single limb support stuff. That's some of the exercises I showed you. where you're doing wall sits or, back extension stuff. I mean, it's all, on the table, and these therapists are very skilled at that. And I just don't know why there's not more, people. You think that they'd be available. Now, physical therapists can do that, but my whole feeling about physical therapists is that, they're going to set you up for doing this stuff on your own. And the trainer is not the one that's, the major thinker in the room. It's more that they can implement and get you in the habit of doing the right technique. And so I'm really big on trainers, just every 6 months to check in with them and just see how you're doing and get some extra ideas and that sort of thing. But bands too, like stretch bands with handles on them, those are really important for strengthening and getting resistance in the legs and the arms without the kind of the heaviness and the tendonitis you can sometimes get with swinging weights around.
Right. I got her contact information. I'll get that to you.
Okay.
Another question, where does recast fit into the prescription treatment for low bone mass?
So reclassed is the advantage of reclass, you can take it once a year. And so it is a very powerful bone stabilizing agent. And so some of this is Wild West, what people prefer, or, some people just the bias of the doctor that you're working with. But it's, it's got a long half-life. It's got the same side effects as Zometa, which is more of a once every 3 to 6 month kind of thing, depending on what you're getting at. But reclass has been used. I mean, I don't think that's a bad drug. It's just once a year. I don't have, much more to say. I don't know the nuance of, but I know that they have the same side effects and, problems like osteonecrosis of the jaw, hypocalcemia. Sometimes you can get some flu-like symptoms with reclass as well.
All right. Also, when on Prolia, is it true that if you go off it, you quickly lose all bone growth? No.
So you don't have a rebound effect with Prolia, any more than you do with Bisphophonates. The idea is that Bisphosphonates actually kill these bone resorbing cells. I mean, they lead to cell death. So they have a little bit longer effect even when you get off of it. And it takes longer for, it has a longer half-life of effect than Prolia, because Prolia is a monoclonal antibody that basically you have to have it in your system to inhibit but not kill those osteoclasts, those bone resorbing cells. So when you stop taking it, you can go back to baseline relatively quicker than the biphosphonates, but it doesn't mean you're actually having a rebound loss of bone. If you know what I mean, it's not you don't have like a rebound. You go back to baseline a little faster with Prolia than you do with say Zometa.
All right. When you have a hip replacement and cannot have a bone density test from the waist down, how do you identify bone loss? Is it enough to just do the upper body?
So the two areas that have been researched enough to give you a score that's reliable are the hip and the lumbar spine. And so you still go in there and get it, and they'll tell you can't get any data on your hip because you got a hip replacement, but you can still get your lumbar spine data, and it's worth getting. The other thing is, obviously, if you've only got one hip replacement, then make sure that they go for the other side.
All right. With myeloma, I've developed osteoarthritis of thoracic spine, and I have high calcium level. Would it hurt me to take a vitamin D?
Well, so there's a few different things packed into that question. In the thoracic spine, I honestly don't think that the myeloma has caused the arthritis in your thoracic spine, but the fact that you have myeloma means you have osteoporosis. You have osteopenia or osteoporosis or low bone mass. That goes along with myeloma. You have all of the conditions for more rapid resorption of bone than if you didn't have the disease. So the answer to that question is yes, calcium and vitamin D. I mean, I would want to know what my calcium and vitamin D levels are. If they're normal, I'd still want to be making sure that I had at least 1,200 to 1,500 milligrams of calcium a day, and I'd want to have 800 to 1,000 of vitamin D a day. If you're low on vitamin D, then you want to go up. You want to go up for a while until your vitamin D levels get back to normal. And that's something that you'd have to have a discussion with your medical oncologist, and they'd be all over that. I mean, if you just have to talk to them about it, but I would be very aggressive about managing your bone health, especially in myeloma. That's one of the worst actors for just generalized osteopenia or loss of bone mass, because the disease comes from the marrow, and it's the myeloma cells induce a generalized bone resorptive kind of phenomena in your bones generally. So you definitely want to be aggressive about supporting that with the proper amount of vitamin D, calcium. Even some modest weight-bearing activity is good for patients with myeloma too.
How does Exgiva injection every 3 months work on the bones? Any thoughts on that?
So Exgiva and Prolia are the same thing, essentially. That they are. It's a fully human monoclonal antibody that interacts with it's a structure on the surface of one of the bone cells that if that monoclonal antibody, called in this case Exgiva, is floating around and it lands on that marker on the bone, then it'll inhibit the bone resorbing cell. So Exgiva is a antibody that causes bone resorbing cells to stop working, and they actually cause them to die early. And so, it causes them to stop. It inhibits. It doesn't cause them to die early. It inhibits them, and so that's how Exgiva works. It doesn't build bone, but it stops bone from being resorbed. It stops that rapid turnover and resorption of bone. And it's very convenient because it's a subcutaneous injection, like a shot.
All right. I think we might have gotten to all the questions. I'm just looking back through. A lot of people saying how beneficial this presentation was. We did record the presentation today, and we will have that available on our website, cscatlanta.org. If you'd like to go back and watch, it should be available in the coming weeks. And just thank you so much, Dr. Beringer, for taking the extra time to answer those questions. That was really helpful. A lot of people talking about how much information they're getting from this that was really beneficial. So thank you.
Absolutely. It's my pleasure to present. Thanks a lot for joining the call, to everybody.
All right, everyone. We'll have a wonderful rest of your Wednesday.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.